Good morning, good afternoon, good evening. We're going to give a little time for people to start logging in. Good morning, good afternoon, good evening, and welcome to the East Africa webinar on ensuring family planning service delivery amidst the COVID-19 pandemic. We'll be getting started in about 5 minutes or so, so just hold on a little bit longer. Good morning, good afternoon, good evening. We'll be getting started in about 2 minutes. Okay, we're going to be getting started now. My name is Lisa Moikambo, and I am the TCI KM lead. And I just wanted to welcome everyone today to the Ensuring Family Planning Service Delivery Amidst the COVID-19 Pandemic. We're going to hear from our colleagues in East Africa, specifically lessons from Kenya and Uganda. Before we get started, I just wanted to provide some housekeeping. If you have any questions along the way of this presentation, please feel free to put them in the chat box or the Q&A, and we'll collect those and share those with the moderator and presenters at the end of the meeting. In addition, there's going to be a recording of this presentation made available on TCI University probably in the next day or two. So you can always find that later. And now I'd like to turn it over to my esteemed colleague, Nathan, who will be serving as the moderator for today's session.
Thank you, Kim, and I also want to add my voice and welcome all those who have been able to join us for this very important webinar. I'm Dr. Nathan Tumbone. I work with JAPAIGO on the Child Initiative program, and I'm based in Uganda. So I'll be a moderator, like Kim has just introduced me to you. So the topic today, like it has been mentioned, is ensuring service delivery amidst the COVID-19 pandemic. And we'll be dwelling basically on Kenya and Uganda to see a few things that we can learn or share. Next slide. So TCI, which is the Child Initiative, of governments to rapidly and sustainably scale up proven high impact reproductive health solutions. And we're looking at the urban poor settlements to be specific. Next slide. So the Challenge Initiative, like I said, has a footprint in East Africa. So, but in this webinar, we'll concentrate more on Kenya and Uganda because of the unique approach that the different governments took to address the COVID-19 pandemic.
Unfortunately, Nathan, your audio is coming in and out.
All right, let me step in on his behalf.
Thank you, Njeri.
Right, so this is Njeri Nyamu. I'm the Regional Program Manager for the East Africa Hub. As Nathan was saying earlier, we work in 3 countries in East Africa, but for this particular presentation, we'll be focusing on both Uganda and Kenya, as the 2 governments had taken similar approaches in addressing the COVID-19 pandemic within the two countries. So far up to the year we're in right now, we've been working in 41 cities. We've been fortunate enough to graduate Kericho, Uasin Gishu, Mukono, and Busia, and Temeke and Ilala in Tanzania. Next slide, please. Our presenters will be 4 for this webinar. We'll have Nancy Alo, who is our Geography Focal Manager for Migori and Nyamira counties in Kenya. We'll have Albert Bwire, who is our Adolescent and Youth Manager for Uganda, and he also oversees operations in the Rubaga division in Uganda. We'll have Nan Assumpta Matekwa, who is a Geography Focal Manager for Vihiga County, and also oversees the graduated counties of Kericho and Uasin Gishu in Kenya. And then lastly, we'll have Beatrice, who is a Geography Focal Manager for Chira, Nansana, and Wakiso divisions in Uganda. Next slide. The objectives of today's sessions are 2-pronged. So the first one is to share Kenya's and Uganda's experience implementing TCI's high impact interventions during the early phase of the COVID-19 pandemic. And we'll also want to highlight some of the tips and lessons we've learned over this period of implementation with you that ensured we maintained our family planning and AYSRH service provision in the geographies that we support. Next slide. Next slide, please. So inviting Nancy to take us through the next 2 slides. Nancy.
Thank you so much, Njeri Nyamu. Good morning, good afternoon, good evening, everyone. And thanks for tuning in our today's webinar. I'm going to share a brief background on the impact of COVID on reproductive health services, more especially on family planning program implementation. And additionally, I'm going to take you through the Challenge Initiative or TCI early response to COVID pandemic in Kenya and Uganda, so as to give us a common understanding on where we are coming from. So COVID-19 has caused a disruption in meeting the family planning needs among the women of reproductive age, hence increasing on the unmet need for family planning. So during this period, we've seen clinical staffs in the TCI implementing city shift focus towards COVID-19 responses at the expense of providing other essential services. Just as known to many of us, family planning is deemed as non-essential during such health crises. Like if you can't remember all the case of Ebola, when there was the Ebola outbreak, focus and attention of most government shifted towards mitigating the spread of Ebola, and hence other essential services like family planning were forgotten. So this has culminated to division of resources to address the challenge. Hence, the health facilities in many places are at the verge of closing or offering limited services. And we've seen where some have converted in, some of the health facilities have been converted into COVID isolation or treatment centers so that they're able to man the pandemic. Women were refraining from visiting these health facilities due to fear about COVID-19 exposure or due to movement restrictions that were instituted by the various government as mitigating measures. Equally, there's been supply chain disruptions causing limited availability of contraceptives in many places, and we've started seeing stockouts of many contraceptive methods being experienced. And if the situation continues in the next 6 months, we see the low and middle income countries having even worse stockouts, experiencing even worse stockouts than never experienced before. Equally, there have been product shortages and lack of access to trained providers, or clinics mean that women may not be able to use their preferred method of contraception. And instead, we've seen women going for more, or women accessing the short-term methods, or some of them may even want to discontinue use of contraceptive methods entirely. And this poses a danger to our youthful population who've been out of schools and higher learning institutions as a result of the pandemic. Hence, we may anticipate an increase in the rates of teenage pregnancies if no measures have been taken into account. And just to share some data, recently, according to a recent report by UNFPA in the month of April this year on the impact of COVID on family planning programs, it estimated that some 47 million women in 114 low and middle income countries are projected to be unable to use modern contraceptives if the average lockdown or COVID-19 related disruptions continues for 6 months without major disruptions of services. And for every 3 months, the lockdown continues, assuming high level of disruption, up to 2 million additional women may be unable to use modern contraceptive. And they further reported, in their report, it further indicates that if the lockdown continues for 6 months and there are major service disruptions due to COVID-19, an additional 7 million unintended pregnancies are expected to occur. And the number of unintended pregnancies will increase as the lockdown continues and service disruptions are extended. Hence, as TCI Tupange Pamoja East Africa, we've worked closely with the TCI implementing cities through the provision of technical coaching to ensure continual family planning and adolescent youth sexual reproductive health implementation of the high impact interventions. Next, please. Both Kenya and Uganda recorded the first confirmed case of COVID around March and April this year. And there were a number of measures that were instituted by the respective governments at the geography and national levels to curb the spread of the virus. At the national level, there was activation of the pandemic surveillance, monitoring and response committees, whose overall role was to provide technical support to the geographies and guidance to the country in terms of managing the pandemic. There was also the creation of isolation and treatment centers. For instance, in Kenya, the president gave a directive to each county to ensure that they were able to come up with a 300-bed capacity isolation and treatment centers, just in case the country experienced a surge in the number of COVID cases. And we've also seen that other measures were equally instituted at the national levels, and these included procurement and distribution of personal protective equipments and the development of policy and guidelines to oversee the implementation of reproductive, maternal, newborn child health and family planning interventions within the countries. These guidelines addressed challenges around family planning and provided guidance to ensure continuity of reproductive health services, including family planning. For instance, in Uganda, all community-based services are being organized taking in consideration the universal precaution on infection, prevention, and that is one area that the guideline really touched on. And in both countries, there was focus around continued use of community structures. And for instance, in Kenya, we've been working closely with the community health volunteers. And in Uganda, we've been working with the village health teams to support continuity of services at the community level. During this period, we saw the community health volunteers were categorized as essential caregivers and were charged with the responsibility of educating household members on infection prevention measures. And as a result, they're able to integrate family planning messaging and distribution of contraception during these important household visits. Other measures included having national lockdown or lockdown in major cities where there was a surge in the numbers, limitation of intra and inter-country migration. Then there's the aspect of avoiding crowding. And in our country, we are having time curfews instigated by the government. And at the geography level, there was the dissemination of the reproductive maternal newborn child health guidelines to all local government staffs, and there was still the reinforcement of some of the national measures and guidelines for implementation during this particular period. Next. So I'll hand over back to Njeri Nyamu to invite the next presenter.
Thank you, Nancy, for giving us an overview of the situation as it was earlier on when Uganda and Kenya recorded their first cases of COVID. In the image you're seeing right now is a community health volunteer actively mobilizing using a public address system to reach clients in Uganda and make sure that they go to facilities for services. We're going now to be taken through some of the interventions that TCI East Africa put in place during this early phase around COVID and ensuring FP and AYSRH services by Assumpta. Assumpta?
Thank you so much. Good morning, good afternoon, good evening, everyone. My name is Assumpta, calling from Vihiga. I oversee Vihiga, and I'm also overseeing some of the two graduated geographies, which is Kericho and Uasin Gishu. I'm going to take you through service delivery, advocacy, demand generation, and also share some of the experiences from East Africa. Next slide. During service delivery, the counties and municipalities were able to respond effectively to FP and AYSRH services to ensure continuity in the face of COVID-19. We have been working with the pharmacists, and we saw the pharmacists being reoriented on commodity provision, including the DMPA subcutaneous self-care service, because the pharmacists remained open actually during this period. And during the same period, we saw that the pharmacists were able to provide refill, and the refill, which is usually 3 months, was extended to about 6 months just because of the eventualities that could exist. We saw also geographies enhancing community-based distribution through the community health workers, which my colleague has already mentioned, and also prioritization of implementation of in-reaches and fixed days. Because of the COVID restrictions, the public gatherings were not allowed, so facilities remained open, and we were able to see the geographies conducting in-reaches and fixed days in Mombasa and Uganda. This is because the facilities remained open and the service providers were also available, although the in-reaches were spread out from the initial 2 days, 1 to 2 days in-reaches to about 5 days, just to ensure that they are complying with the COVID-19 guidelines. Also, there was a strengthening of facility family planning services, integration to other service areas, HIV, maternity, and also the clinics where we saw mothers coming to the facilities for clinics, and also the deliveries remained ongoing, and therefore clients were able to get postpartum family planning during delivery. And again, we saw quite a number of partners coming in to support the government in procurement of personal protective equipment. And in this picture, we can see even TCI was also part of the the partners that supported the national government. Next slide. Under demand generation, there was enhanced use of the social media platform, for example, the WhatsApp, the Facebook. In Uasin Gishu, there were Facebook platforms where the youth were able to be reached, Twitter platforms, and also the use of the local radio shows where our geographies sent the healthcare providers to the radio program, the local FM programs, to ensure that the clients are reached through the media, the local FM media stations. There was also equipment of the community health volunteers and the youth champions and pharmacists with IEC material on FP during the COVID sensitization meetings. Next slide. Within the activities under advocacy, the counties were able to reach out to the family planning champions and facilitated them to advocate for service delivery during the COVID. Some of the champions are also part of the community health workers or the resources that exist within the community. You can see in the quote by Sister Rita Namusisi, a midwife from Gongwe Health Center in Buikwe, Uganda. She was talking about how pandemic has demonstrated the critical role of the VHTs, that is the village health committees and community health workers in community health and ensuring that the services have been provided. These are actually some of the heroes we have had to recognize. The facilities were also open. We are seeing another quote here from Sister Naikoba Lona from Jeru, also in Uganda. And she said, even during lockdown, we never closed our facilities. It remained open. So again, we can see our healthcare providers remained able to provide services to the clients. Also, there was key leadership engagement to sustain financial commitments and allocation. And we were able to see the geographies conduct PIT meetings virtually to ensure that there was a use of program performance data for decision making. Some geographies also had technical working group meetings like Uasin Gishu, and some of us were able to participate in those TWG meetings, especially looking at the data, the perceived data for increased pregnancy and sexual gender-based violence during the pandemic. There was distribution of the FP commodities and coaching on the national FP service continuity. When the guidelines were released, then there was a need for the geographies to be oriented to the new guidelines and the recommendation. And of course, there was an element of engaging the youth to see how they will fit in the new guidelines, because we saw youths usually are reached during gatherings where they interact, but during the COVID-19, there was limited interaction with the youths. And so we saw the geographies taking actually the youth-led activities to reach the other youths. The issue of the leveraging from partners and FP commodity, we saw DKD, we saw the banks coming in fully to support, and also the other business community. Next slide. I'm going to share learnings from the TCI implementing sites, and I'll just go quickly during the COVID-19 pandemic. We've talked about the use of the local radio stations to create awareness and also relay key information during the pandemic. Promoting continuity in terms of community-based distribution of contraception, and also the pharmacies, just to bridge the gap that existed when there was fear for clients reaching the facility. And then, of course, prioritization of PPE, which is a motivation factor for the service providers who are equally at high risk of getting the infection. And some of them also, we saw quite a number of health workers reported to have been testing positive. Then it is important also to look at the fixed day and in-reaches particularly to lower level facilities, which are next to the communities where the clients live. This is very critical. And then there was the support of virtual engagements, which are very feasible and productive, although there's need to have frequent interactions. And when you're reaching the youths, even though the youths have the access to Facebook, they have challenges in terms of the cost implications that go with it. Then engagement of the private sector was very critical to provide family planning, because the private health facilities that exist, lower level private facilities remained open, and these were able to provide continuity of the FP services. Next slide. This is just one of the photos where we can see a provider welcoming clients for family planning services in one of our facilities, supported by TCI East Africa. Back to our moderator, Jerry Nyamu.
Thank you so much, Assumpta, for that clear insight of what TCI is doing currently in the geographies that we are implementing. As we go on, we want to also look at the data and what is the data telling us in terms of all these initiatives that we have begun. And I'll be inviting Albert Bwire to talk about the data and what we have seen so far in our implementation efforts. Welcome, Albert.
Well, thank you so much, Njeri. And thank you to everyone who has found time to join in this webinar. Okay, next slide. Oh, thank you so much. So the slide you are seeing looks at data, and we are trying to compare FP service uptake in the face of COVID. So looking at two types of contraceptives, you're looking at the lax versus the short term. And what you are seeing here tries to depict when TCI started implementation in East Africa, and also trying to see the uptake of family planning. So the line you see, the line that is in color blue represents short term, and then color purple represents lax. So like you can see right from the beginning, there was actually an upward trend in terms of uptake of lax until when we're hit by COVID. So around the period of March 2020, when the East African countries reported their first cases for COVID, that was in Kenya and Uganda around 1st of March and then 20th of March, we saw a deep decline in terms of lax uptake across the two countries, Uganda and Kenya. But when you compare that to short term, we see short-term methods were not affected. And that could be, the reason one is that as East Africa, we supported the geographies to engage the VHTs and the youth champions and the community health volunteers to continuously distribute commodities in the communities, but also the engagement with the pharmacies continue to ensure that there was continuity of FP uptake, especially for the short-term methods. So that's what the graph shows. But also what we learned from here is that COVID really affected FP service uptake. And then also, just like it affected other essential health services. Next slide, please. Thank you. So this slide is looking at effect of the government restrictions on the FP service uptake. And we are using the 12-month FP rolling sums to show what really happened. And like you can see, we are seeing that Uganda, Kenya, and Tanzania, and Uganda and Kenya, they took similar direction on lockdown to limit the COVID infection. But that had a daunting effect on the FP service uptake. Like you can see right from March, there was significant dip in the two countries, Uganda and Kenya. But of course, if you look at Tanzania, which did not have lots of restrictions, you can see it wasn't really affected. And that really tells us that COVID-19 had a significant effect on FP service delivery or uptake, just like it had effect on other essential health services like maternal newborn, and then malaria, and then other services. And then lastly, we also want to look at now, looking at this, we realize COVID is here to stay. So we are not sure when COVID will be ending. So as a program, we need to prepare ourselves. How do we move forward? And what have we learned implementing FP services during COVID that we want to move forward, that want to take on to ensure our service continuity during COVID? Next slide. So what you see here are some of the most significant change stories of how young people, or what we call the youth champions, have been able to support their fellow peers to access sexually reproductive health services, including family planning. And this just signifies some of the works that young people are doing in different spheres of life, in different localities, to ensure that their fellow young people continue to access services. And this is contributing to, one, to FP service uptake, but also in the long run, reducing on teenage pregnancies. Next slide. So having talked about that, we feel that we need to ensure that the service continuity. And we think that for us to be able to implement, to ensure service continuity for FP services, targeting women, men, adolescents, and youth during COVID, then we must address different aspects at different levels. And looking at the facility, we strongly believe that we need to have engagement with the pharmacies and the drug shops, but also engage the youth champions to ensure that they distribute commodities in the communities to those who need them. And then the other thing, we need to strengthen integration of family planning services into other health services in the facilities, but also in the community. And then we need to encourage self-acting methods, but also ensure availability of LACs to reduce on facility visits. So because LACs, they give more way of protection, and therefore it will limit on the amount of exposure for the clients, but also even for the providers. And then the other thing, we need to strengthen active case management and screening of COVID during outreaches and inreaches. So we need to ensure that facilities, that whoever is conducting outreach, you must ensure that we are screening the clients who are coming, you are taking their body temperature, but also ensuring that you have water for them to wash hands. And then also those who are suspected, they should be able to be isolated, and they should have mechanisms of linking them to the national COVID response team. And then the other thing is we need to ensure that if you're organizing outreaches and inreaches, then you need to have more days, but also have more providers providing the service. That will limit on overcrowding and also ensure compliance, but also a limit on the amount of exposure that the clients will have while receiving the service, including the providers. And then lastly, we need to have helplines to ensure that clients do not necessarily come to the facility to seek for information and counseling, but they can easily call in and be counseled. Next slide, please. At policymaker level, we think we need to address issues related to the availability of trained human resource. So if we want to ensure continuity of services, we need to have the right providers in place with the right skills to ensure that they provide the services to the clients. And then the other thing, we need to continuously advocate for provision of long-acting reversible contraceptives, because like I said at the beginning, they provide more couple of protection and therefore limit on the in and out of clients coming to the facilities to access the services. But also they can all withstand the shocks that come with the supply chain. And then lastly, we need to prioritize provision of PPEs for health workers, but including the community health volunteers. That will motivate them to provide the services and ensure that our clients receive family planning and AYSRH services. And then lastly, at the city and national level, we need to enhance partnerships with the private sector and looking at the pharmacies and drug shops, because research shows that adolescents and youth prefer to access contraceptive services from drug shops and pharmacies. And therefore, we need to strengthen engagement to ensure that our young people are able to receive the services that they need. And then lastly, we need to strengthen monitoring and evaluation to ensure that we track on our commodity supply, but also on the data that is being generated. So we need to ensure that the geographies are using the data to make decisions, but also the data is driving all the interventions that we are implementing. Next slide. Okay, thank you so much for listening to me. Over to you, moderator.
Thank you so much, Albert, for that session. Again, just a reminder to all the participants, we are taking in questions and answers at our chat box. Feel free to indulge us, and then we will be responding to your questions after we finish the presentation. I'll call upon Beatrice to take us through our going forward, what has TCI learned and what do we anticipate to do. Welcome, Beatrice.
Thank you so much, Njeri, and thank you so much the previous presenters. You've given the situation, what it was, what we have done, and what we are learning. We are still learning more. In my presentation, I'm going to give cost considerations of COVID, also look at the high impact interventions and how sustainable are they, and kind of a takeaway home in future. What do we intend, what do we think we can do when we face pandemics like the COVID? So now over to cost considerations. Next slide. You realize that when COVID actually landed on us, we were not prepared, and we started doing things in a way that would actually give us results. We had a slump. When you look at the graphs, we had a slump in our performance, but because of the manner in which we started responding to the situation, we've started going up. Our graph has started going up. So the way we have responded to the situation includes using virtual meetings for technical assistance and coaching staff. Before COVID, we would have a chance to really go down in the geographies, have physical contact with physical talking with the geographies, and we'll be able even to validate what was happening down on the ground. But with the coming of COVID, there was restriction in actually going down into the field. So there was a lot of more virtual meetings, a lot of calling. We had to use a lot of internet. And as a result, and this is something that we had actually not budgeted for in our implementation budget. So as a result, the cost for maintaining these virtual coachings and communications went high. We also realized we needed to develop IEC materials to reach the targeted groups. IEC materials which were integrating messages between family planning and COVID-19. This is also something that we had earlier on not planned for. We had to design these messages, we had to disseminate these messages, and it was an extra cost, much as it was able to help us get up from the shock of the COVID. We also, like my prior presenters have said, purchase of personal prevention equipment to ensure that our staff and our voluntary workers are not infected, and also to protect the clients that we are serving. This was a big cost, and thanks to other implementing partners who actually worked together with us to make sure that we have PPEs for all service delivery programs. This is something that we had not actually budgeted for. So it was an extra cost during COVID. Like other preventers have told us that in activities that we're actually doing, the high impact activities, we had kind of to adapt to the situation. For example, the outreaches, the enriches, which were being conducted deeper down in the communities at lower level facilities, to try and as much as possible to reach the clients nearest to their places because of restricted movement. We ended up having to use more days because of social distancing, the whole process of being checked. You have to wash your hands, you have to sanitize, you have to social distance. So you ended up using more time. We ended up using more time serving fewer clients. So the more days that we used to serve the same number of clients definitely made it more expensive. This was the same thing even with outreaches. So it was a cost that was also incurred. The community health workers who are responsible, those are the community health workers and the VHTs who were responsible for mobilizing clients for services, for enriches, for the outreaches. They were given extra services to do. They were given the duty of making sure everybody who comes washes. So they did the sanitization. They were also given the duty of checking their temperatures. They were also given the duty of making sure that they social distance the clients. So they also, in other words, their mobilization and participation in these outreaches gave them more days. So we needed, and they are volunteers. So they needed to have lunch. They needed to have transport back and forth. That was all, it all increased the costs for serving a client during pandemic. Next slide. So now we ask ourselves, we've shown that we have been able to adapt to the COVID-19. We have shown that we are moving out of the shock that the COVID-19 actually brought on to us. And why, we ask ourselves the question, why are we able to do that We are about to do that because we are using TCI approaches, high impact approaches, the challenge initiative, high impact approaches. So we're asking ourselves a question, why these approaches are they actually really sustainable? So what does the ability to adapt COVID-19 tell us about the TCI approaches and their sustainability? The results are out. We realized that despite the challenges brought about by this COVID, the performance of the challenge initiative high impact FP interventions in the TCI sites and the service numbers were not badly affected. Yes, we know we had a slump, but we are recovering from that slump. We had the slump because we had not envisaged this COVID. So that shows that the interventions that we are actually giving, the TCI interventions, have got a significant impact on sustaining family planning services in the communities. So despite the TCI team not being fully physically present in the geographies or in the municipalities, we have experienced counties, municipals, local government plans, which have incorporated high impact interventions in their geographic plan without us having to tell them. So that shows you that the seed of the challenge initiative approaches has actually germinated in our geographies. And as long as it has germinated, there is evidence that it is actually going to grow. So the TCI interventions are actually sustainable. We also saw that some TCI interventions had been included in guiding the documents to guide service delivery in the pandemic. The way TCI does its work is being kind of looked at as what needs to change in the ways how the government is working. So collaborating with other various sectors, no, not collaborating. So, but the government, the service delivery, the way TCI service delivery was being conducted during the COVID has influenced government to change service delivery because of the manner in which we were doing it. We also realized that there was a lot of collaboration with other various sectors to enable, like other members have talked about it. We started collaborating with private partners to make sure pharmacies and drug shops are giving services to the young people and other people who need them. There was a lot of collecting money and other resources to mitigate the crisis situation. And this shows that the TCI approaches have actually infiltrated in the geographies where we are partnering to look at every other resource within the community, continuing to advocate for increased resources for the interventions. They don't have to wait for an NGO to come and give them money so that they can be able to answer a certain program. No, they are proactive. That shows that TCI interventions, again, are actually doing what? They are showing that there is sustainability due to the interventions. Also, the fact that the geographies were able to take the high impact interventions like the outreaches and the enriches deep down in non-TCI supported facilities shows a diffusion of the uptake of the proven interventions. So sustainability is there because of the TCI. The TCI approaches really show the sustainability. They won over the COVID situation. Next. Now this slide, so after all that, after what we have learned, after what we have achieved, what are we going to do post-COVID? It's coming from what we have achieved. We need to continue with multi-sectoral networking. including every other person, every other interventions in the geographies, not working single-handedly, not working in parallel, but make sure everybody comes on to fight to make sure that FP services are given to the people. We need to continue having advocacy for continued resource allocation. We've realized that resource allocation is very, very important in ensuring the fight against, in ensuring family planning services during the COVID. We also realized that we were caught unawares. We did not have any risk mitigation plans. So we ended up having to spend more where we had not planned. So from now onwards, it's important for us to do a risk mitigation plan to factor in response to health emergencies. Also, we need, together with the physical presence in our geography, it is very important to sustain virtual coaching sessions. It brings in a lot of harvest. Proven interventions should be implemented according to the quality standards. Like our last, Albert was saying that monitoring and evaluation, being able to use to ensure that the interventions are being implemented according to the standards. And how should we be able to ensure that they're being implemented according to the quality standards? We have what we are going to look at in our next slide, please. Next slide. We have the TCI University. The TCI University, where we urge you, all of you, to log in and register with the TCI University, where you're going to find a lot of valuable information about high impact interventions, high impact family planning interventions. You will also find there the COVID and family planning reproductive health curated sources. I urge you, our university will be assured of continuous learning with you and us. I urge you to actually open it, register, and start reading and learning with us. Thank you.
Thank you so much, Beatrice, for that take through on what we have learned and what we are going to uphold as we move forward. I'm going to request Assumpta to take one question from Mahin, where she's asked that, can we speak more about our work on DMPA, SCI, and what specific activities have we done to add DPMA to the VHTs, CHWs, and pharmacy basket? And I think, Beatrice, you should start because Uganda, you've been on the forefront of doing this. So if you can kindly take that question and kindly respond to Mahin and the participants.
Sorry, the question, sorry. Can you speak more about your work with DMP? This is Sayana Press. What specific activities were done with the VHT, CHWs, and the pharmacy basket? Yes, in Uganda, we've been scaling up. Okay, DMPA subcutaneous is a very, a simple, which is locally known as Sayana Press, gives us a chance to be able to inject yourself. It has the injection and has I'm sorry, it got me unawares. A person can be able to inject oneself using the DMPA Sayana Press. So in Uganda, we started a program where health workers were trained to give DMPA, as well as train VHTs, as well as train clients themselves to be able to inject themselves. So there is already that environment which was already there, which made it very easy for the VHTs to give Sayana Press or DMPA subcutaneous. And it was also very easy. The pharmacies have also been trained because they sell the Sayana Press, and have been trained to be able to train the clients to inject themselves. So that's the environment which had already been prepared in our countries. And it is being scaled up all over the country.
Assumpta, do you want to add on to Beatrice's response?
Yes, thank you so much, Njeri. In addition, I would say JAPIGO has done studies on cyanopress in specific counties in Kenya, including the counties where we work, Mombasa, Migori. And during this pandemic, we were able to see counties bringing the stakeholders on board and collaborating to feed where there is need. Although TCI does not necessarily deal with commodities, we have other partners who are dealing with commodities. For example, the Luala community and the Maristops Kenya, which also have the Sayana press with them. And they were able to sensitize the healthcare providers and also the community health workers to provide Sayana press in their respective areas where the country has already allowed. And of course, the private facilities are selling this. This has come in handy, and that goes along with the orientation of the pharmacist, which was done in areas where we are working. Thank you.
Thank you so much, Assumpta. We have a question by Kalen Ateka. What are the observations in terms of advantages and disadvantages of virtual meetings? I think one of our learnings has been with virtual meetings, you're able to engage more people, and you're not limited by space, and also the fact that it's a bit more cost effective in terms of having to support transportation costs for various participants. So we found it to be a bit cost effective in comparison to person meetings. But then again, one disadvantage is the aspect of being able to prove what is happening on the ground. And there are situations where you really want to verify that actually what is being undertaken on the ground is what is being spoken about. I think both virtual meetings and face-to-face meetings have their advantages and disadvantages. But so far for us, the key learning we've seen from the implementation efforts we are undertaking is the fact of it's a very cost-effective means of engaging a wider population of health providers, a wider population of community healthcare volunteers. You're able to disseminate more information in such gatherings in comparison to one-on-one meetings, where like now where we have limitations to the number of people that you can gather within meetings. I'll ask Nancy to respond to a question from Megan, where she's asking, and thank you so much for the comment about our webinar, we appreciate. She's asking, should want to hear more about healthcare providers, and are they open to providing family planning during this pandemic? Are they fearful of COVID transmission? Have you had to do any work with them to reassure them? I think, Nancy, please proceed to respond to that.
Thank you so much, Njeri, and thank you, Megan, for the question. Yes, I can say that the health providers in the TCI implementing cities are open to provide family planning during the pandemic. And like any other human being, initially when the first case was announced in Kenya, there was fear, and fear was all over. But again, being that there were national guidelines that were developed, as TCI, we played a role in ensuring that coaching on these guidelines are done at the geography level, and more so coaching on infection prevention. We went a step further and procured some of the personal protective equipment. And when we gave these equipments to these particular geographies, the healthcare providers now were relieved because now they were safer to provide this particular service. And again, we saw that being that they're humans like any other humans, but they have the call of duty. Hence, as a result, family planning was deemed as one of the essential services and was needed to continue during this particular period. So yes, they are free to continue with the provision of family planning services, even amidst the pandemic. Thank you.
Thank you so much, Nancy. We'd want to appreciate a comment by Jacqueline Ondieki from Nyamira County. I hope we will have an opportunity to share what Nyamira County has been doing in terms of family planning uptake in the Kenyan space, just to see that you are recognized by the Council of Governors. Would really want to hear that more, and I hope we will have a session where we can share that. I'll hand over back to Lisa just for a few guidelines on way forward.
Thank you so much, team. It was great to hear from all of you, your various perspectives, and awesome to hear about the adaptations to the high impact approaches to meet this critical time and what that means in terms of possibilities for being responsive to future emergency situations. We thank you all for calling in and attending today's presentation, and we will make sure to have the recording and PowerPoint slides up maybe within a day or two. So please visit TCI University, and we put in the chat the COVID page specifically. We'll collect your questions. It looks like a number of the panelists were able to type in responses. We hope that's sufficient, but if you have additional questions that we weren't able to get to, please feel free to email TCI Urban Health, info@tciurbanhealth.org, and we'll make sure to direct you to the respective person who can respond adequately to meet your needs. Thank you once again to our esteemed colleagues and presenters, and for all those who attended today. We will be in touch for future presentations and webinars. Our Francophone West Africa team will be presenting next Wednesday about the situation specifically in that region. So hope you have a good rest of your day or evening, and we will be in touch again soon. Thank you.